I'm a King Edward Medical graduate. And later on, I became more interested into healthcare delivery management solutions. So that is my specialty. So I'm doing consulting. I'm also Director, Canada, Pakistan Research and Development Council. So I welcome all of you. And today we have selected quite a different topic on my request, because sometime we should have some other issues which are extremely relevant in the change of the outcome of any healthcare intervention. So we have with us Raheel Waqar, who is the CEO of White Rice. So Raheel started his entrepreneurial journey at the age of 21, curious about solving problems. His first startup was a design and animation company where he, by accident, came across the development world, which was trying to solve mass-scale social challenges. That accident, or a turning of fate, led to Raheel dedicating his career to help mission-driven organization achieve real change and sustainable impact. To achieve this mission in 2006, he started up White Rice, a behavior change agency that has impacted over 10 million lives across 13 United Nations Sustainable Development Goals, and is now a leader in the social impact space in Pakistan. Raheel is a recipient of the Australian Business Leadership Excellence Award, a Bohem Media Fellow, and was selected as Asia's top 100 entrepreneurs under the age of 30 by the Foundation for Youth and Social Entrepreneurship. He actively contributes to his field by serving as a speaker, advisor, mentor, facilitator, and board member. Raheel's moonshot is to impact 100 million lives by 2030 and make Pakistan a hotspot for social innovation. He is a graduate from University of Southern Queensland with postgrad from University of Pennsylvania and Southern Queensland. And we are also joined as a panelist, Dr. Noman Ashraf, Program Director, Psychiatry Residency Program, KCU, GME, Consortium, Ozark Center, and a Clinical Associate Professor of Psychiatry at KCUMB, and a Medical Director, Addiction Services, Ozark Center, and the other fellow panelists from APPNA Merit, like Dr. Prasad Zaman, Dr. Danish Bhatti, Dr. Fareed Suri, so all of them. So just to save the time, I will request straight Raheel to share his journey with all the participants and the impact. So over to Raheel.
Thank you, Dr. Zair. It's a very elaborate, introduction. I hope I live up to that. All right, so let me just put this on the screen. I hope everyone can see it.
Yes.
All right, perfect. So thank you, Dr. Zair, for the opportunity and APPNA Merit to be here today. I was just saying, I don't think I've ever been in a group of so many doctors in one room or virtual room. So it's been an honor to be here. I'll just deep dive. It's an interesting day to have this presentation, September 11, very historical day. So I hope we don't make big movements, but I hope we make some behavior change in process. All right, so two disclosure statements. One is that there is no financial disclosure or conflict of interest in this presentation. And the second is that I am a very non-academic in this room. Mostly things that I've done is from a practitioner's perspective. So they might not be academically sound. I haven't done the RCTs around a lot of stuff, but I would say for sure that there is a lot of user-generated insights, things that we work very closely with communities. And that is definitely what I want to share with you. And sometimes those insights are more valuable because they really build more empathy and more connection in terms of the response that you're trying to do. So very briefly, as Dr. Zaid mentioned, I run a behavior design agency, which is focused on changing behavior. So we work with big organizations like the United Nations, international NGOs, local NGOs, and donors. I started this company 15 years back, and till today, we delivered over 500 projects across 13 SDGs and impacted more than 10 million lives. So I want to break down this word because it sounds very different. It's a different type of word, behavior and design, and what do they do together? So fundamentally, all our actions, everything we do is a behavior. It is a outcome of something that we do, which is ingrained in the way we do things, which we call habits, routines, behaviors. And in one way or the other, those behaviors are designed. They're either designed in childhood or they're designed by mentors, peers around you, or the environment that influences you. Or for good or bad, it's designed in a way which you can influence. And if you can positively influence them, you can actually get people to do the right behaviors, which I think Dr. Noman can talk more about because that's his area of specialization. But the work we do in essence is designing or nudging people in the right behaviors. So how we do that is the journey that I'm going to take you through, and how we've done it in the past, as an example. Some context I want to build here is the problems we work on are very systemic. So they involve individuals, they involve families, communities, and a lot of stakeholders around them, which include the government, nonprofits. And until all these pieces don't work together, change really doesn't happen. And that is why a lot of times we see fragments of change which are not sustainable because the entire system hasn't changed. And I think that's a dilemma in Pakistan that we commonly see. The other thing is that these are wicked problems. These are problems that are not easy to solve. We've been, I think, addressing them for the last 50 years, from health, education, climate change, a lot of these issues that we've always had. And the very nature of them makes it very difficult to address. So a lot of people shy away or they attempt to make those changes, but things don't move in a significant manner. These are large scale interventions. We're really talking about people because we work with the masses. So this is on average from 100,000 people to 2 million people. Some interventions have even gone up to 5 million people. So these are very large scale programs that we work with, mostly rural. So we're really talking about the 70% of the population that is out there that is not digitally connected. So that even complicates the challenge, because if you have a digital device, it's easy to nudge people or remind people of behaviors. But in a non-digital environment, how do you do it on a regular basis becomes a big challenge. Mostly around SDGs, as Dr. Zaid pointed out, UN SDGs. So we've worked on 13 Sustainable Development Goals, ranging from poverty, women rights, to health, education, water and sanitation. The other challenge here is that these are repetitive behaviors. Now, people familiar with behavioral economics might know that nudging people into a one-time behavior is relatively easy. You can install just-in-time or in-context triggers that get people to park in a certain lane, stand in a certain way, keep a distance. But when you need to get people to change the very way they have been doing things and change one behavior and replace it with another and make that behavior permanent over a longer period of time, that requires a lot of thinking, a lot of understanding of human behavior and human context. So they're not easy in that way. And outreach is the biggest challenge. The places we work in, the luxury of media, mobile phones, even a lot of these places don't even have, these people don't have smartphones. They're basic feature phones, and one family has one phone, that type of situation. So it's really, a lot of our work is dependent on the frontline worker, the health worker, or whoever the last mile service delivery, whoever's doing that. So that's the context in which I'm going to talk about today and go deep into. So I'm going to share 4 case studies with you, 4 examples of the work we've done, and I'll try to leave some time for question answers in the end. So let's start with my favorite project, which we did 6 years back. It was a child stunting project for UNICEF. And we were basically doing this project in Sindh. I'll give you some details. And the project was called Misali Ma, and in Sindhi it's called Misali Mao. So the details are that, as some of you may know, that Sindh is a province where 50% children are stunted. So this is every second child. We were targeting 3 districts in Sindh, reaching the actual reach was around 90,000 mothers. But directly, our intervention directly for 3 weeks was done with 26,000 mothers at that time. And the key focus was the first 1,000 days of a child's birth on around 5 key behaviors, which included early initiation of breastfeed, the first 6 months, and then complementary feed in the next 2 years, hand hygiene, especially a lot of issues related to that, mothers taking supplementary pills and multivitamins, and stuff like that. So that was the entire program delivered over 3 months. So our entire program was designed in a way that the entire intervention point was 90 days. So this is just an idea of what we were basically doing in terms of fact finding. So our most of our work starts with a lot of in context research, which is formative in nature, more ethnographic in nature. So you can see focus groups, key informant interviews. But I think our most revealing part was observations, where our researchers actually embedded themselves into the families of these communities and spent 7 to 8 hours in one household. So you can imagine the amount of data, the amount of empathy that we had to build to really understand why people do what they do, what are the barriers in the behavior, where are the challenges, where are the points where the behavior really doesn't take place, or intervention points, even possibilities or opportunities for intervening. And then we do a lot of visual ethnography. So we really capture a lot of visual data, which speaks volumes. As it said that a picture is worth 1,000 words. Sometimes when people are trying to say something, so it's really trying to see what people say and what they do in that real environment. So in that process, we use a technique called projection technique, where we get, when we were doing this research, because our target audience was mothers, we got them to project what an ideal mother would look like. And in our context, because language and literacy is a big problem, a lot of people can't read. So a lot of these statements, or even write, were written by a facilitator. But the lady that's drawn in the middle was drawn by a community member. And that is a very powerful tool, which we underestimate, that the power of visuals, no matter who you are, even if you can't write or read, you have the power to draw and illustrate. So we actually asked these mothers in these sessions that draw what an ideal mother would look like to you. So they would, beautify it, they would put it together, and then we would ask questions like, why did you have, why is the hair of this style? What type of clothing print do you have? What other features do you think that an aspirational mother should have? And those insights led to a very interesting, there are many insights, so I'm just going to share some ideas. So this was like some of the visual communication that was developed as a result of what we were doing. And if you look at the mother here, right in the center, I don't know if you can guess it, but one of our insights was that when we talked about aspirations and we asked these mothers, like, what is a personality or a character or a celebrity that you really resonate with, or you feel home-like? It's who do you connect with? And interesting, in that community, in those areas, because they use satellite dishes, so wherever they have TV, they have satellite TV, and there's a huge Bollywood influence. So they were very influenced with Madhuri. And Madhuri, as a Indian celebrity, film celebrity, came up again and again. So if you can, I don't know if you can now connect with it, but the mother has features of what Madhuri would look like. So the idea again was that how do you build an immediate connection when you show your visual communication? And how do you build something that people aspire to become? Because aspirations, everyone has aspirations. Your income bracket doesn't really matter. At the end of the day, everyone wants to progress, wants to grow. So from details like that to giving visual cues, like what an ideal home should set up like. So we gave these different visual cues where we would ask them to pick a family and really come down to the fact that it's not about economics. It's really about a lifestyle choice, that do you want to live a lifestyle that is healthier because of things that you adopt, or do you want to live a lifestyle where you constantly someone's getting ill, your children are ill, which at the end of the day creates economic burdens. And then the other thing we did was that we created these mother clubs where we got every 15 days, we would get mothers into these clubs with their mother-in-laws. And it became a safe space where they could really talk about issues and things that they were facing, things that were top of mind, problems that they were having. And we also had an opportunity to do these emotional demos that we call emo demos. And these are bringing ideas to life. Now, in this example, you can see this lady, one of our facilitators, holding two bags. One bag has milk, and the bag represents what a child's stomach looks like in the first few months. And in the other bag, we added the junk food that is usually given in these communities, which include chips and biscuits and stuff like that, and especially during the first 6 months. And the idea was here that once you see both bags, we show like this is your child's stomach, and then the one that's mixed up, that concoction that you can see on the left, is basically we put it in a glass and we ask someone to drink it, and usually people shy away. And then we try to make a point that if you're not having this, imagine this is what you're giving your child, and how unhealthy could this be? If it doesn't taste good, imagine what your child is going through. So a lot of these ideas were brought to life. And this is another example where hand hygiene, which is very relevant to COVID-19 as well, where we used glitter, and we got two volunteers from the group. We would put glitter on their hands and ask one person to wash it with soap and the other to wash it without soap. And the one without soap, the glitter would remain. And then we would encourage them to go into the people that are around there and ask and shake their hands with other people. And usually people would shy away, but if someone did, those germs would shift to someone else's hand, and then we would complete the cycle and ask that person to go forward. And that is how we made something invisible visible, and show how germs actually spread if you don't wash your hands with soap. Similarly, a lot of role play activities where we would change roles. We would get mother-in-laws to become a daughter-in-law, and a daughter-in-law to become a mother-in-law or a sister-in-law, and see how the situation looked like from the other side of the lens. And this was another very interesting activity, a lot of interesting insights. We started recognizing and rewarding these programs. As the name suggests, Misalima, one thing that really came out was that the mothers were already doing so much. A lot of times they didn't have the physical ability to feed their kids. And myths like colostrum, for example, is a milk that is usually wasted in these communities because it's thought that this milk has gone wrong and it's not given to kids. So in that process of celebrating them, appreciating them, trying to get them to do things, whoever completed our program would get a certification. You could see at the bottom, we had these wristbands that were made to create that sense of identity and connection in that group. So this really became the talk of the town in that community, and everyone really started feeling special and started feeling recognized through the work that we were trying to do. Outdoor, indoor triggers and prompts that we were designing. So you can see on the left side, there is a home-based trigger where we remind people in different places what behaviors they need to perform at home. There were outdoor triggers to remind them about the program, to keep them on track. We had real-time monitoring that was done by our team, where they would just go and observe how the facilitators were delivering the program so that we could improve the program as it was being rolled out. So we launched this as a pilot initially for 3 months so that we could go back and understand, and in that process, improve the delivery program. Lastly, what we did was we did a story circle exercise where we went back to 11,000 mothers after 8 months of the program being rolled out. And we asked them to share their most significant change story. So what happens is they sit in a group and everyone shares a story. And then within that group, those mothers nominate what the best story is. So we eventually ended up gathering around 3,500 stories. And out of that, 10 significant stories were video documented, recorded by mothers themselves. So it's a participatory technique where we facilitate the process, but the mothers basically ask the questions from another mothers. They're even involved in the editing process. And those stories are then showcased in the communities later on as positive deviant stories. Because what we're really trying to prove that people within the same community, within the same means, if they have managed to change, what has enabled them to do it. So they become local inspirations and role models, and we get men involved, we get local government involved, so that everyone starts seeing the power of change that has taken place. One other aspect that I really want to talk about is the behavior change model. So there is a professor at Stanford, he has BJ Fogg, who coined a behavior change model that we use a lot in our work. It's called BMAP. And what he claims is, and we've also seen the evidence of that if you want to influence someone's behavior, you need to focus on 3 things simultaneously: motivation, ability, and prompts. Motivation is really about keeping rewarding people and keeping them engaged in the program, inspiring them. Ability is really talking about how do you make it easy for people to do a behavior. And we know from, you're all health practitioners, we know for experience that There are so many things we know are right for us, but we don't do it because they're difficult. And the moment they become easy, it becomes, the habit loop becomes easier. And prompt is really about how do you nudge them, remind them, trigger them about that behavior at that right time. And what was very significant about this is that when we were trying to train thousands of frontline workers on the model, we said, how do we localize this? So eventually we came up with our pyramid of change, Tabdili Ka Tekon, which we call. And it stands, and we were able to localize the entire model into three things: Kahani, Asani, Yaad Dehani. So Kahani talks about motivation, inspiration, Asani talks about ability, and Yaad Dehani talks about trigger. And I'm very, proud to say that today thousands of frontline workers have been trained on this model, which really at the core talks about anything that you do. Whenever you're communicating with communities, these three cues you should remember. Are you making it easy for them? Are you inspiring them, telling them a great story to connect with them? And how often and frequently are you reminding them about those behaviors? So and then we use technology to monitor and to nurture outreach workers. The impact, which I think is the most important thing in this case, after 8 months when we went back and we did this 11,000, we engaged with these 11,000 mothers, which is around half of the community that we originally engaged with the 26,000 group. 90% of mothers were able to report a behavior that they were still doing after 8 months of the program being rolled out, which was very significant. And they were able to tell how that they retained that behavior, what triggered them, and how they're still practicing it on a day-to-day basis. And as a side thing, which we had never had the attention to do, but we ended up doing the world's largest story gathering exercise with 11,000 mothers. So two big things for us in that space. So I'll quickly jump into some work that we did with HIV reduction amongst the transgender community. This was a project funded by UNFPA. Again, a very difficult community to work with. High rates of HIV at that time. It's a very close group, so entering that community is very difficult because they have very strong social norms. And honestly, they're not interested in instructions or trainings or listening to you at all, and telling you about HIV messages. And what the other interesting part is that most of the people we talked to, I think more than 80% knew the harms of the practices they were doing and causing HIV, but they were still not changing. We went deep again. We had very in-depth discussions. So there is a concept of peer educators in this group. And these peer educators are people who belong to the same transgender community. And they take on the role of educating other peers on safety messages. So we had very in-depth discussions on lifestyles, on stories, on anecdotes of how these people operate. It's a universe, to be honest. We spent 2 months with this community and fascinating people. And then we also shadowed. So we would go into situations, we would sit as silent observers and see how the sessions would roll out. What were the common questions, common queries, common pain points, frustrations that were being discussed during these conversations? And then what we realized, we could never ever design the right solution for them sitting in isolation or sitting in a room thinking about those ideas. So we then took another approach and we said, all right, let's co-design it with them. So these are some of the initial illustrations that we designed. So we eventually made an animation series, which was a animated drama series, which was used to create a conversation. So they would see the series, the animation, one episode, and then they would talk about it. And these were some of the initial illustrations we made, and we got very, very honest and bad feedback on this, that this looked horrible, it looked like a housewife, we don't even look like this and all that. And then we said, all right, let's do it together. And this is the result of it. You can see a lot of the colors, the vibrancy, the jewelry. This is how they want to look. And to be honest, unfortunately, when we're designing for the communities, whoever it is, we overlook these things. But these things mean a lot when you're trying to create that bond with them. And as a result, as an outcome, we were able to co-create artwork with them. This community has their own language, which is called Farsi. It is not the actual Farsi that is spoken in Iran, but it is a coined term that they use. And it's a script that they use, which we cannot understand. So we contextualize it by using those words and phrases so they can connect with it. Then we even use transgender voiceovers on our animations so that the empathy and the connection and the familiarity was immediate, was instant when they would watch something like this. And all the conversation within these edutainment-based content was scenario-driven. We would put a scenario there in a dramatic format and leave it with a cue that it would go on to a conversation. And what we got when we got feedback, we heard that after watching one episode, they would actually have a 30 to 40-minute healthy conversation around what should have happened in that situation, what could have been done, how did I handle a situation like this. So we created a subject that was a taboo, didn't want to discuss it, to a very lively conversation and constructive conversation on how to solve the solution together. I'll go on to my third project, which is something we did during COVID. And this was around changing behaviors on nutrition and diversity of food in Balochistan. Again, a very challenging environment in a challenging time with a very challenging audience as well. Again, Sindh, Balochistan has a very similar situation in terms of Sindh, even maybe worse in terms of mother health, where 50% plus children are stunted again. We were working in 8 districts of Balochistan and targeting around 11,000 families. So this was over 100,000 people in total in terms of impact. And this was the first time that nutrition and a balanced diet, a balanced food plate was being discussed in these communities. And unfortunately, it was so skewed that if you look at the food variety, people usually just have one form of food, maximum two in a food plate on an average meal. And so it was really, really bad. And mother health was really suffering, especially lactating mothers and mothers that were pregnant. So what we did was we said, how do we make this so simple that people in these communities could start connecting and immediately start understanding what we're trying to do? So we made a visual repository of communication guides, which included things like these, and also included things that they could immediately remember. So the 5-hand principle was a concept that we used here, so that they could remember the food types on their fingers, and breaking it down with the local context. So we also broke this down further in terms of, because Balochistan is a very diverse area. You have people from Makran, you have people who are actual Balochis, and then you have Pashtun Balochis, so people who are Pathan but live in that area, and they have very diverse societal norms. They have very diverse food types as well. So you could see how elaborate we were able to design these programs. Again, these were delivered through frontline facilitators, but we literally broke it down to like what meals you need to have in the morning, or what options could you have in the morning, during lunch, in the evening, at night. How do you break down your food? How do you make sure it's hygienically clean? So very simple visual instructions that even if they couldn't read, they could connect, they could actually remember and recall. Another big challenge in this case with these type of programs is that you can design the ideal program, but if people, as I pointed out, ability, if you can't get these people to source the material that they need, and if sourcing the raw material becomes difficult, nothing's going to work. So FAO has this amazing program where they develop kitchen gardens. So they help these women basically set up the garden in their vicinity and also manage it. So a lot of the fruit and vegetables and things that we were talking about were then easy to source and bring into their dietary patterns. So this is one fundamental thing that happened. The other was that no matter what amazing food, if it tastes bad, it tastes bad. You don't care about healthy food at the end of the day if it doesn't taste good, right? So what we did was we brought in the best chefs from the community who were great cooks. And we looked at existing recipes and we said, all right, how do we integrate diversity in food into that, into the regular food and the food that they enjoy? So we did these cooking demos, and our entire 12-week program, again, we focused on 12 weeks, was around, if there was one week of sessions, orientation on a subject, the next week was practicing it. So whatever they learned, they went into a kitchen and literally they would start making the food themselves. They would learn how to do it, and then they would come up with the best taste that they could from those existing recipes, integrating the other food types. And another very important thing is that we don't map intention to action. And that is a big gap in a lot of programming, where we don't think of how this is going to happen. So we tell people what to do, and they respond with it. But what will they do? How will they make it happen in their daily routine? It's something that we miss out usually. So we actually went out and developed a program. So wherever we would have these discussions with these mothers and these female members, we would actually make them, if they couldn't write, we could make them narrate how would they bring this practice back to home. And our facilitators would then write it for them, sometimes visually draw it for them, and they would take it back and put it up at their home so they could remember, and it became a pledge as well that this is what I'm going to do and this is how I'm going to do it. How is actually very important, which we sometimes overlook. And as the program, as we speak, the program is actually being rolled out now beyond 8 districts. So it's being rolled out across Balochistan. And FAO is now integrating this program because this is the first time a comprehensive program of this nature has been designed across Pakistan, across the work that they're doing. So the results are still coming in. We actually implemented it last year, towards the end of last year. The program is being rolled out, but we're really looking forward to some very exciting insights. So the last thing I really want to talk about is the Clean and Green initiative. You might have heard about the Clean and Green Pakistan initiative that started during the latest government, around tree plantation and waste as well, and hygiene. So we were able to basically adopt the umbrella program into a provincial program that Punjab government was doing with UNICEF. So this was the government, UNICEF, and us working together on this program. This program was centered around 5 behaviors: tree plantation, hand washing with soap, open defecation, which is a big issue in areas in Pakistan, sorting, disposal, and clean and safe drinking water. Our biggest challenge here was that we were told very upfront that the government doesn't have the resources. They can't put in a lot of money, so you really need to get the community to do it. And as daunting as it sounds, getting someone to do something that they just don't like doing anyways was very, very difficult. So our entire campaign was centered around this main character called Mithu, and who was basically we in India, Pakistan, the Jugaad mindset is something that I think is very uh, home to us. And we said, how do we bring that mentality of resourcefulness into the work we do? So rather than waiting for someone to come and help you, what could the communities and individuals do on their own to start making the communities safer, better, and more healthier at the end of the day? So you could see with these type of behaviors where we got tree plantation, but we also got recycling into action. So things like these we started to introduce. Again, what happened, one of the biggest challenges in this program was that we had trained our frontline workers. These were government workers that were ready to deploy, and then COVID lockdown happened. And this happened last year. And suddenly all the program came to a halt. How do we go about doing it? So we very quickly were able to develop a offline online program and continue the rollout. Until today, it's a success story in UNICEF Pakistan, where as most programs had to stop, our program still continued. So these are some examples of how the outreach worker with limited engagement, field interaction, were able to engage the communities. We developed village wash committees, which are basically village representatives who take ownership of the tasks that need to be done. So they're constantly in contact with the community, sharing information back with the frontline workers, guiding them on what's working, what's not working, so that they can improve the program. During lockdown, we developed a lot of content that we were able to transfer through young people in the communities who had smartphones, and especially around COVID-19 messaging and the program messaging as short videos, actual videos, animations, and they would get these communities to sit together and watch something and then have a discussion. So in a remote setting, we were able to keep the community engaged, keep them discussing the issues. This is some of the outdoor branding that we did, again, as reminders. You can see a flag up here where we try to create the salience that people who achieved these 5 behaviors, they were very prominently outside of the community were represented. So you could see this flag that meant that this home is a clean and green home. It is a home that achieved the 5 behaviors that we were targeting. Another very interesting thing that we generally don't recognize is the outreach workers. They are key to any program delivery, and I think we've seen that in polio and a lot of other interventions as well. And during this time, no one wants to get out of their home, safety, a lot of other issues. But what we were able to do was take their stories, make them the champion, and you can even see them becoming a superhero in some ways, and celebrate their work online. So we had created a parallel community online with 50,000 users on that community, where we would regularly share what they were doing on the ground and what the communities were doing on the ground with that social media platform. So we were able to recognize them, reward them, and celebrate their outreach achievements. So these are different examples, and this has been phenomenal. We can't tell you how effective this was, because the moment someone saw, nobody basically saw themselves being featured on social media and hundreds and thousands of people liking it, sharing those videos, they suddenly, these unsung heroes became mainstream heroes. The world recognized them, the world could appreciate the work they were doing. And this is some of the monitoring, real-time monitoring we were doing. We were using simple tools like WhatsApp, where they would share their activities on a regular basis, and we could, give them feedback and share that material later on social media. As a result, during COVID, we were able to achieve this massive target of 50,000 latrine constructions, toilet constructions in these communities, which was phenomenal. We actually overachieved the target during COVID. We engaged 30 million people on digital media and 2 million people directly on ground on COVID messaging and regular program activities. And what was also very interesting was that using technology, using these different tools, we were also able to reduce the cost delivery of this program. Because now, where multiple partners are required, the government channel was already there. UNICEF was supporting us and some of the work on the ground, and we were just guiding these people, facilitating this, and developing the right means to creating that behavior change at the end of the day. And this is still ongoing. The eventual target is over 10 million people in the long run, which is still being in the process. So lastly, I'll just talk about a few quick key takeaways. Context is the king. I think it's very important to understand the situation, the location where the behavior needs to take place. Behaviors fail because we don't understand the environment. If you don't control the environment, you don't control the behavior. It's as simple, but it's as critical as this. We need to design for empathy and co-create with users. Empathy is key, and user engagement is very important. Social proofing, the way you establish norms and the way you get people to see something, because people follow people. And if you're able to establish that from the very get-go, you can create a very strong influence. Positive deviance, again, a very important part of this entire thing, where you can identify local heroes who are doing the things, because they are true inspirations at the end of the day. Aspirations, I talked a bit about that. How do you use key visuals, stuff that people want to become, think about their dreams and connect with that part of the things. Making it simple and easy, I think, is another very important aspect. Creating routines and breaking habits into micro habits. This is a big discussion, but I won't go into detail because I think we're really running out of time. And experimentation, that's one thing that I'd say is key. I know in the medical and scientific field, we talk a lot about experiments, but unfortunately, when we come in the real life situation, we forget experimentation. We call it failures. This doesn't work. But experiments, when you look at it from a lens of experiments, that means that you've tried something and now this doesn't work. There's another way of doing it. And iterating, I think, is the most important thing. And don't underestimate the messenger. The last mile is critical, so we need to design for them. Thank you.
Thank you very much, Raheel. It's really phenomenal and a really fascinating experience. And this is real Pakistan, 70% of Pakistan. Pakistan is not only in Lahore, Islamabad, Karachi, or Peshawar. This is real Pakistan, and these are the real issues, and that is the impact of behavior change. It's really phenomenal and wonderful. People were so much engaged among the participants. And now I'll request Dr. Noman Ashraf to really add something and may ask any question he has to Raheel, please.
Well, first of all, thanks, Raheel. This was wonderful presentation, and I think the work you are doing is really good, trying to really make the change. So I think he covered most of the important elements in a project that you would implement in a community. What I wanted to talk about was, suppose you have an individual with you and you want to make a change, and then you can take those examples and and take them to the community level and take some of the work that Raheel said will make sense. So when we talk about change, as Raheel mentioned, one element of that triangle was motivation, and that is the key. And we have two approaches, right? So if you take medical example, a patient comes to you and has high lipids. The, so the traditional approach is prescriptive. We tell them, okay, so you have hyperlipidemia. If you don't take care of this problem and your weight, then you're gonna have heart issues, you're gonna have a stroke, and you're gonna have other complications, you may die. This is you talking to them and you're telling them these are the problems and this is what's gonna happen. But the patient is just listening to you. They do not have a buy-in into this process. So now the field is changing. It's changing from prescriptive interviewing and suggestions to more of what we call motivational interviewing. And the premise is basically Miller was the guy who came up with this, and then Rolnick did some work on it. But what you are trying to do is trying to tap into their intrinsic motivation, and you use collaboration. You use some sort of like their autonomous thinking. The premise is that the patient or the person you're working with, your client, has the ability to make the change, and they are the drivers. You are not the driver. You are the facilitator. So that's a little bit different than telling them what's wrong. Rather than it's more like an approach where you're collaborating. So they always say in the older approach, it's like a wrestling. So you butt heads with them because they start arguing with you, and if they don't want to change, you're like, oh, the patient doesn't listen to me. What can I do? I've just given them the instruction, given them medication. They don't listen to me. Rather than that, they call it, this is more like a dance. You help them and collaborate with them. So if a patient says, I don't want to take the medication, you don't say that, well, it's not, medication is not good for you, you shouldn't take it, but you stay with them and say, okay, well, let's explore that. Seems like it's very hard for you to take the medication. Why that might be. So that kind of approach is more motivational, and you want them to have the inner motivation to make the change. When we talk about the change, there are certain stages of change. So there were these two guys, Prochaska and De Clementi. They came up with this model of change that you may have read about, trans-theoretical model, has different phases, but the first two are the ones that's where you have to do most of the work. First one is the pre-contemplation. They're in denial. I have no problem. I don't want to change. The other one is contemplation, where they're ambivalent. They have both sides. I want to change and I don't want to change. I feel stuck. So that's the phase where you can help them out, and you can use this motivation interviewing technique. And I'll share the example how you use it, like practically how you would do it. And then the other phases are, once they move on from here, they say, okay, I want to make the change. Then you prepare them. It's called preparation. Then they make the change. They pick a date. It's action stage. And then they move into the maintenance phase. And then after maintenance, they can go back to the same behavior too. They may start taking their medication. Suppose if it's someone who's struggling with drug abuse, start using drugs. Like Raheel was saying, the moms, they had good habits, but they go back to it and they start using the same type of milk. So there may be relapses along the process, and you bring them back into the chain, and you may have to start from the pre-contemplation, contemplation phase, and do the cycle all over. So let's take an example of, I think the most common would be, say, non-healthy eating. Like we all can relate to it, and I can give you another, like a substance abuse example, if it makes more sense. So people who are interested right now, if you want to be with me, you can take a piece of paper, pen. You can make maybe 3 broad columns and 3 broad rows, and I'll show you. Let's write something. I'll show you on my screen. So if you make those columns, you can write the pros and cons at the top, and then on one side you can write the non-healthy eating, and then the other side you can write the healthy eating on the column side. So now once you have these quadrants and you're working with your patient or your client, you can have any behavior here. We're just taking the eating behavior, put down any behavior, and now you ask them. And always when you start off anything, like Raheel was saying, empathy is big. You got to put yourself in their shoes and feel like how what they're going through. So one of the things they did was role play, which is excellent. So you can feel like what they're feeling. So how do you build empathy? Well, you really want to show respect, genuine respect. You really are interested in, like if they say somebody drinks alcohol, well, tell me, what do you like about it? You're going to start off with that. What do they like? This is something that's helped them, maybe with anxiety, maybe with social embarrassment. So this is something they love. You don't want to say this is bad and you shouldn't use it, because that's the negative approach. That's going to push them away. Tell me about it. What do you like about it? So you engage with them. You validate their feeling. If they say, yeah, it helps me with anxiety. Well, yeah, so there's some benefit of it that you see. So like then you're validating their feeling, and you're making that report along those the interview. So say pros would be, so if it's a non-healthy food and you're in the pros column, they may say, oh, I feel good. I'm a foodie. I like to eat food, and that's what I like. Okay, then you can ask them anything else you can think about that you like about it. Well, I like to socialize with my friends, and when I go out, I eat with my friends. Okay, they may have other reasons too, but you start with the positive so you can engage them. You don't push them away. Then you can say, well, but is there anything else you've noticed? And if they talk about something unhealthy, I've noticed I've gained weight. That's fine. If they don't say that, then you can say, okay, you told me about all the things you like. Are there something that may not be so good about eating? And so you're gently asking them, and they would say, yeah, I think I've been struggling with my weight, and due to the weight gain, my lipids are up, and I've developed hypertension. I have to take the pill. So those are the problems. And then because of the weight, I just cannot move around as freely I used to be, used to do it, and then I cannot breathe. So you can put those down in the cons column. And then you come down to the other section where it's healthy eating. So suppose if you were to replace it with healthy eating, what would be the advantages? So my health would be better. I would be able to breathe better. I would be able to move around more freely. I'll have more energy to do work. The next column would be the cons with healthy eating. Well, if I'm doing healthy eating, I guess I'm gonna miss that taste of the food, and I'm gonna miss that euphoria. Okay. And it will require a lot of effort on my part because I really love food. So it's gonna be very hard for me to do it. And maybe it will be awkward for me in social settings when I go out with my friends and they are eating the great food and I'm eating grass. So it's maybe harder for me. So you put that down, and the reason is why you're putting down, and the patient is with you, you're bringing their attention onto the positives and the negatives. Again, patient or client is the one who's going to make the decision. You're not making the decision. You're there to support. And so that's what you do. And then I can give you like a really quick example. If you take a substance instead, suppose it was not food, it was alcohol. They may say they feel good, they use for anxiety, it helps with their sleep. The cons would be now they're separate from their family because their kids and their wife don't want to see them because they've used so much alcohol. They've caused issues to the family. They have legal issues, they have financial problems. And if they're not using alcohol, the pros would be they can get to be with their family, their health would be better, they will be financially better. And the cons without alcohol, again, they'll miss the taste, euphoria, and they'll have anxiety and other issues. So once you bring their attention, then when you get to the action plan stage, you can help out. So it seems like you have some, you see alcohol helping you or the eating helping you, but you also have some concerns about your health, you and your family. And you leave it up to them. The pressure's on to them. That's the key in motivational. You are just doing reflections. So whatever they say, you just reflect it back to them and wait for them to say, yeah, I see there's a problem. And then once you get to the action space, you can say, okay, so if anxiety was an issue, are there other ways we can look at it? And then you can come up with the medication or other thing. But the key is using the motivational interviewing, understanding the change model, and then being respectful and helping them out to get through it. And we'll see if there's more time I can actually share more, like how would you do it in a session, like with a patient, you can share the script too. Thank you.
Thank you very much, Dr. Numan. It's really excellent addition. Danish, do you have something to say?
जी, अस्सलाम वालेकुम. I have a few points. पहला मेरा couple of suggestions हैं Dr. Mr. Raheel Waqar साहब के लिए. I think there is a big need for behavioral interventions in HIV. We have a subcommittee on HIV who has been doing primary care education for HIV. I can share some details and connect you with our subcommittee chair, and we would love to do a session with you for our physicians on these kind of tools and techniques and understanding, and maybe even design some projects together on HIV. Second, हमारी जो कमेटी है जिसमें हम challenged हैं बहुत ज़्यादा behavioral aspect में, वो है cardiac resuscitation. So we have a committee on basic life support and cardiac resuscitation that basically has this vision of teaching BLS to all Pakistanis, just like in North America and Europe. It's common for people to save life by being trained on BLS and knowing how to do cardiac resuscitation on site and having that approach. Like in Pakistan, mein ye understanding nahi hai. And we have been trying to create these models of universal education in BLS, and we thought we'll start with physicians community, and even there we're feeling resistance. So it's a culture change that we need to bring in a behavioral change, and we're not sure how to crack that code. So that could be a project, together that we can talk more about, and I can connect you with the chair of the cardiac resuscitation committee. The third point that is a question for Waqar Saab is that आपने nudge की बात की. I'm sure आपने Richard Taylor की किताब पढ़ी होगी, nudge की, और Daniel Kahneman का भी work पढ़ा होगा. So I think there are some low-hanging fruit. हम behavioral modification पे बहुत बात करते हैं, which is the most challenging aspect. But there are some design modifications. आपने थोड़ी सी उस पे बात की, but I would love your comments on जैसे nudge में खास तौर पे Richard Taylor का focus है कि by changing the default settings, you can improve the outcomes where people don't have to change their behavior. They're still going for the most knee-jerk reaction, but you change those default settings for them. Donors पे उसने काफी studies की बात की है, organ donation पे, and savings पे वो बात करता है for public servants in investments or default saving rates and things like that. So I think कि पाकिस्तान में ऐसे बहुत से शायद issues हैं जो कि defaults अगर हम change कर दें government की तरफ से या private setup में, that could improve things even without having to tackle the behavioral modification. Thank you.
Thank you, Dr. Danish. We have Dr. Farasad Zaman. Do you have any question, Dr. Farasad?
Thank you very much, Dr. Uzair. Very wonderful work. I think I must congratulate Raheel for this excellent work. So we are actually, I'm working under hospital settings or in the research labs. We are always very narrow, looking at the stunted growth under the microscope, trying to find explanations, how this is, happening. But we always forget this, that the behavior has a huge impact on the growth of the child. And since most of the clinicians are here in the session, and they would agree with this, कि जब आपका stress level body में ज़्यादा होता है, the cortisol production body में constant आपका वो high रहता है, जिसकी वजह से अगर एक बच्चा जो है वो constantly अगर stress environment में है, तो वो उसको आप अच्छी न्यूट्रिशन अगर दे भी देंगे तो उसका इम्पैक्ट उस तरह का नहीं पड़ेगा जब तक हम उसके जो बिहेवियर है उसके सराउंडिंग में से उसका जो उसमें से जो स्ट्रेस का एलिमेंट है उसको अगर हम टैकल नहीं करते. So I would strongly suggest if you can add something to train the mothers or to the community there, because one of your project is about the stunted growth, right? So उसमें जो है, if you can add this element of how to we cannot completely remove stress, but how to decrease the level of stress in the surrounding environment for a child, for example, from the family, from the others or something. I think that would be very, very beneficial overall in this project. So that is one.
Thank you for the input. Dr. Sarwat, I see you around. Do you have any question or comment, please? Dr. Sarwat Hussain, are you there? It appears, I think he's not there. So I think
I'm here. Ji, Assalamu alaikum.
Please.
Sorry, I was muted.
Please, do you have any question or comment?
Sir, my question comment actually. This is a fantastic presentation, and we have been in healthcare have had problem in change in behavior of let's say doctors, nurses, and paramedical staff in washing their hands and in infection control. If इनके जो methods हैं, they're so good. If we can implement them, we can really save lots of lives. मेरा भी यही comment.
Thank you. Thanks a lot. I think it was a wonderful presentation, and people, I think this was change of taste because we were discussing some innovation, and that these are the social aspect. So thank you very much, Dr. Danish. Now you can really thanks to all the participants, and say something before the close, please.
Let me see if Raheel Saab has any final comments or concluding remarks for everyone. Before we conclude, we have 5 minutes. Raheel Saab, please unmute yourself and go ahead.
Sure. So thank you for the very valuable feedback and very interesting questions. If I may, I just want to quickly address a few things that Dr. Danish, you've also mentioned. I would love to be part of anything that you're doing and in any way possible to address those issues. I think HIV is a very big problem. We're actually sitting at another pandemic when it comes to HIV, especially amongst drug users. We're also actually working on a project right now. So it'll be very interesting to touch base on that separately, and the BLS part as well. Nudges, one thing that I just want to clarify that nudges are amazing, and I think at a public level are really critical. So we've already been in discussion with the government. They've set up a special behavioral unit within the Planning Commission. So there's a lot of discussion around how to use nudges and behavioral science. The Qatar Nudge Foundation is also working with them. So there is work happening in that space, but everything takes light ages. It's going to hopefully happen one day. But जो डॉक्टर सरबत ने बात की, I think that's very critical, that hospitals के अंदर there's a lot of evidence of nudges being used in those behaviors because those are one-time behaviors. Those, you can actually influence people in that environment. The challenge with us is that we, one, have to get into people's heads because these are repetitive behaviors. Nudging them into that behavior because they don't have control a lot of times on the context, it becomes very challenging. And that's why we have to go the extra mile of changing behaviors and nudging. So the trigger part comes from that. But I think that's a very valuable input. And I think that is something that we could look at from the hospital's perspective as an experiment, because that can be done. Those defaults could be set. You could actually create an environment where people, without cognitively processing what they need to do, they can be pushed into a certain behavior. And the last point, I think Dr. Faraz talked about reducing stress in the child's environment. I think that's a very important point. But unfortunately, the problem, sir, is that we put too much burden on the one individual, which is the mother, and that is the biggest problem in a lot of the things that she's constantly burdened, and then we want her to do more things. So the surrounding environment includes the men in the home, the mother-in-laws, the other people that I think play that role where the mother can actually do. So I think it's a great suggestion. It's really required to do. And I hope we can, continue this work and build it up. But thank you so much for patiently listening. I think Dr. Mann, you added a very interesting insight to it. Sorry, I think I've taken up a lot of your time in this conversation. But hopefully next time Dr. Mann gets a major share. Thank you, everyone.
Thank you so much. So Raheel, I think we'll be looking forward to collaborating with you more. There are many areas that we need your help on. For example, I was thinking we are looking at launching this whole idea of chatbots for patient response and queries in healthcare. They will need a lot of default settings and behavioral components built into it. We talked about the resuscitation and HIV, so I'll definitely connect you with our committees, and I look forward to learning more of your work and working and collaborating with you. Thank you everyone for joining. Let me hand over to Dr. Zair for his closing comment and close the session. Dr. Zair.
Thank you very much, Danish, Raheel, Dr. Sarwar, Dr. Noman, and Dr. Farasad, and all the valuable participants and guests. It was really something very, very interesting to me, very close to my heart, the behavior modification. And I think the APPNA Merit will be in touch with Raheel in the future as well to do something together. So thank you very much for your time and patience. And we close with this dot on time. So thank you very much. Take care and goodbye to everybody.
And also it's a message for us to change our behaviors that need to be changed, that we know need to be changed.
Thank you and bye.